Hi, everyone, and thanks for joining us today. Before we start, I again want to thank the Dietitians and Nutrition Support Dietetic Practice Group of the Academy of Nutrition and Dietetics for funding this initiative. Today, we have Dr. Ayers with us. Dr. Ayers received his Bachelor's of Science and Doctor of Pharmacy degree from the University of Mississippi. Dr. Ayers is currently employed by Baptist Medical Center in Jackson, Mississippi. He is a clinical specialist in nutrition support and serves the Department of Pharmacy as Chief of Clinical Pharmacy Services. He is also a clinical associate professor with the School of Pharmacy at the University of Mississippi. Dr. Ayers is currently the president-elect of the American Society for Parental and Oral Nutrition, also known as ASPEN, and is a past chair of ASPEN's Parental Nutrition Safety Committee. He's a member of the USP Compounding Committee and chair of the Parental Nutrition Subcommittee. He served the last 5 years on the USP Healthcare Quality and Safety Committee and as chair of the Parental Nutrition Expert Panel. Dr. Ayers was awarded the Aspen Excellence in Nutrition Support Education Award in 2011 and the Aspen Stanley Serlich Award for Parental Nutrition Safety in 2016. Dr. Ayers was named a fellow by the American Society of Health System Pharmacists and the Mississippi Society of Health System Pharmacists. Dr. Ayers has served as president of the Mississippi Society of Health System Pharmacists, Mississippi Society for Parental and Oral Nutrition, and the Mississippi Pharmacists Association. So he is very well qualified. I don't know how he has time to sleep, but we are so thankful to have you today, Dr. Ayers.
Well, thank you, Stephanie, and feel free to call me Phil. I appreciate that. So a lot of Mississippi there, wasn't it? So I was pretty impressed that you could get all that out. So it's great to be with you, today. I'm looking forward to this. And I told Stephanie, I thought we would just talk a little bit about refeeding syndrome. I'm going to reference a consensus recommendation document that was published actually in 2020 that I got to be a part of, and I was very thankful to be a part of that process. And it's a pretty interesting paper to be involved in. And in my practice, primarily parenteral nutrition, although I do some enteral nutrition, we do see these candidates who are at risk of refeeding. I know with the patient population that you see as well in your practice, this is certainly something you're mindful of. I think my concern is that, I've been in nutrition for, over 30 years now, and I'm really seeing a lack of nutrition education, obviously in the medical schools and the schools of pharmacy, schools of nursing. And we're sometimes don't really have a good understanding of what refeeding is and, who is maybe at risk of refeeding. We see this quite often at my facility, and oftentimes we're consulted, to begin maybe parenteral nutrition, who's at risk. And we have done as a good bit of education in that, we've got to get some baseline labs and before we can initiate PN. And in PN, parenteral nutrition, obviously it's not a stat therapy, it's not an IV fluid. And so that's sometimes a challenge. And I've talked to some colleagues across the country, and although I do like the fact that we do have some commercially available multi-chamber bags out there that you may or may not have seen in practice, I'm a little bit concerned sometimes that people see those more as an IV fluid than as parenteral nutrition. They certainly are parenteral nutrition, and sometimes they'll initiate those maybe at a higher rate than we normally would if we were compounding the PN. So a lot of gaps out there, to be quite honest, in education. So I'm looking forward to just discussing with you today and see what your thoughts are and get some feedback from the group. And these are just my disclosures. So we're going to talk about refeeding syndrome, discuss what patients are at risk, what populations that we need to certainly be aware of, and talk about some common signs and symptoms that one might see in a patient at risk for refeeding syndrome, and then how to address the nutrition in these patients at risk. And it can be, parenteral nutrition. I've had patients refeed on enteral nutrition as well. I think sometimes there's a little bit of misnomer out there that this is just parenteral nutrition, but it can happen really with any nutrition. Anytime you introduce, especially carbohydrates, patients are definitely at risk for refeeding. Just a little background here. We all know that when you look at refeeding syndrome, it's certainly this constellation of all these abnormalities of electrolytes. And when we start reintroducing nutrition, especially carbohydrates, in patients who have been starved or who are malnourished, they're at risk of possibly refeeding. May or may not be aware of the Minnesota experiment, a very interesting experiment that was done in the 1940s. And there were 36 conscientious objectors of the war who agreed to go into this study Dr. Ansel Keys was actually the primary researcher here. And so probably something that we couldn't get through an IRB or through an ethics committee today, but we learned a lot from the Minnesota experiment that we use even today in practice. And if you're a historian, you know that back in World War II, we also saw individuals develop refeeding syndrome, primarily prisoners of war, concentration camp victims who were essentially starved. And once the nutrition was reintroduced in these patients, some of them died of cardiac arrhythmia, some died of respiratory depression. It's always really thought the hallmark sign is hypophosphatemia, and that is somewhat true, but there are other signs and symptoms too to be aware of. We certainly can see depletion of magnesium and potassium. Thiamine deficiency is something we always think about in patients at risk and can lead to some mental status changes. These patients can seize, can lead, unfortunately, to coma and death if we don't initiate parenteral nutrition or enteral nutrition appropriately and address some of these abnormalities that these patients are experiencing. So this is just a quick slide here talking a little bit about refeeding syndrome. Again, if we have a patient who has prolonged starvation, severe malnutrition, we know once we introduce nutrition in this patient, we're going to see things like gluconeogenesis, catabolism of protein, eventually even fatty acid catabolism occur, which leads to production of ketones. We know also in these patients, there's severe electrolyte depletion, vitamin depletion as well. We see a reduction in their rate of metabolism. Insulin secretion is also decreased too in this prolonged starvation or malnutrition state. So once we reintroduce nutrition and primary carbohydrates, that metabolic rate will increase. We see increase in insulin secretion, anabolism will also increase as well, uptake of glucose, and all this will increase the demand for ATP and oxygen in these patients. We also see an uptake of phosphorus, potassium, and magnesium. Again, that's where our depletion occurs once we reintroduce this carbohydrates. And patients are also going to be utilizing more thiamine. So this is where we can get in trouble, especially if we try to feed these people too fast and we don't correct some of these abnormalities that we see. Hallmark symptoms here in terms of electrolytes are hypophosphatemia, hypokalemia, hypomagnesemia. Again, as I mentioned, thiamine deficiency, and I would say probably the newer literature really doesn't focus that much on sodium water retention, but if you go back and look at some of the older studies, they mention that. You can even see some glycemic issues as well as in these patients. So it's very important that we really understand, you know, from a pathophysiology standpoint, what's going on with these patients, what can happen if we reintroduce nutrition too fast, at too high a rate, or too many kcals or carbohydrates per day. And this obviously can lead to refeeding. So many of you have seen these pictures. Unfortunately, this is the Minnesota starvation experiment. So you can see pictures of these men. Again, we learned a incredible amount from this experiment. As you can tell, they look like, you know, concentration camp or prisoner of war, World War II men, if you will. And so again, a lot was learned from this particular study that even today probably cannot repeat this, but we owe these men a lot who are willing to go into the study. I don't know if you're familiar with this paper, but this is one that I was involved in. It's pretty interesting. It was actually brought to us by a emergency medicine resident, Josh De Silva. So Josh actually approached Aspen because he was seeing these patients refeeding, even in the ED. In his practice, he was in the Air Force, completing his ED residency, and came to Aspen and said, you know, that he had some difficulty finding maybe some really good information on what to do with patients with refeeding syndrome, was kind of getting bits and pieces. And David Sears, another physician from Columbia in New York, really helped spearhead this as well. And he helped Josh in this particular consensus recommendation paper. I was fortunate enough to be able to kind of oversee this paper. And it really was the work of the Parenteral Nutrition Safety Committee and the Clinical Practice Committee of Aspen. So both committees developed a task force, if you will. They were composed of dietitians, nurses, pharmacists, physicians. And really, this group was charged with developing a consensus recommendation paper. What we did know is that we couldn't do a guideline paper. Sometimes people call this a guideline paper. It's really not, because when Aspen does guidelines, they're using grade level recommendations to make those guideline recommendations. Again, not enough literature, not enough randomized controlled trials to do this as a guideline. And so this ends up being really an expert opinion type of consensus recommendation paper. Now, I think that doesn't lessen this paper by any means. I think it does give us some good practice guidelines, especially for clinicians who are maybe new in practice that may or may not be familiar or have seen this before. So Aspen actually does a number of these type papers. I was involved with a consensus recommendation paper on parenteral nutrition. So we did that paper along with a guideline paper. So in the questions that couldn't be answered by a guideline, we actually had a consensus recommendation paper. You'll see the same thing happen with the new critical care paper. If you're familiar with the Aspen critical care paper that was just published recently, there's also a consensus recommendation paper being done. So they're able to answer through expert opinions some questions that could not be answered via the grade method. So Aspen, I think, does a very good job of this. And again, it's really a means of educating people on nutrition. If you've not seen this paper before, it's really outlined very well. There's a background. It even mentions some case reports, goes through those. And that's what you find a lot in the literature when you're looking at refeeding syndrome, a lot of case reports out there. It walks you through the pathology, talks about how to screen, assess patients, outlines the populations that are at risk, how to avoid refeeding syndrome, and then gives you maybe a clearer definition and recommendation for not only adults, but also pediatric patients as well. So this paper has been well received. I think now at this point, it's been cited over 125 times, and it's really was published in 2020. So that's really done well in terms of people utilizing the paper. This is actually a table from the paper. It talks about those patients at risk, and you may have seen some of these in your practice, right? Those patients that maybe are chronic alcoholics or have some drug use disorder, patients, any type of things like dysphagia, eating disorders like anorexia. I've seen a number of those in my career. I even saw one feed that was on enteral feedings that refed, and people were a little surprised. It didn't surprise me, but they were not familiar that this could happen in enteral nutrition as well. Hyperemesis gravidarum, I see some of those patients in my practice as well, and I've seen a few of those refeed. Think about patients with cancer cachexia, obviously at higher risk as well. Some of our post-bariatric surgery patients, we've seen that happen. Anytime you have a patient who is any kind of prolonged fasting, could be a patient on a hunger strike or maybe even a refugee. So those keep in mind that, these are the type of patients who are at risk. And I think this is where we've got to do a better job of educating, some of our physicians, our nurse practitioners and PAs, some of those who are providers, if you will, making them aware of who's at risk and kind of what you do with these patients. But identifying the risk, I think, is really important. And this is, even in my institution, we've struggled with this a little bit, especially with our hospitalist group, not being necessarily familiar with some of these patients at risk. So this, I think, is a very helpful table that if you're using it for education purposes, it's a nice breakdown of patients who we're concerned about. I know that you guys are primarily seeing your ALS patients, and this is an area where I don't have a ton of experience. So I appreciate Stephanie sending me an article that she actually published and did a really nice job. And I appreciate that. I learned a lot from this article, and she addresses some of the common barriers for consuming adequate nutrition in our ALS patients. So those, because they do have dysphagia, they can be hypermetabolic in nature. They can suffer from things like constipation, excess drooling, decreased appetite, depression. All those things like that are definitely barriers for these patients to consume the adequate nutrition they need, protein and calories they need for maintenance. And so it can be definitely a challenging group. She also mentions in the paper here about gastrostomy tubes. Like a lot of nutrition, right? When you look at randomized controlled trials, they are somewhat lacking in this area, but looking at some observational studies, it would suggest that there's definitely a survival benefit in these patients that cannot tolerate their nutrition by mouth, maybe dysphagia for some other reasons. So it would make sense that we try to address this through the use of G tubes. And so some nice indications outlined here in the paper as well. So those patients who have insufficient nutrition or hydration. So those that are losing weight or have the clinical signs of malnutrition, we want to address with a J tube. Those with swallowing difficulty, prolonged meal time. So in other words, it takes a long time for them to eat. They can't maintain their nutrition or provide accurate nutrition by mouth. So these are patients I know you see in your practice, and primarily will have G tubes, and again are certainly at risk for refeeding as well. So we keep these in mind, and we want to be sure that we're getting all the appropriate baseline labs and we're addressing their nutrition and addressing it in a slow manner, and working our way to that goal rate for enteral nutrition is really important in this group of patients as well. So back to the refeeding paper, it does a nice job of outlining some of the signs and symptoms, and certainly not going to read all these to you. I will be glad to share these slides if you'd like these. But looking at hypophosphatemia, this is one that I see quite a bit, right? And I've seen actually patients develop some neurological issues. I've seen patients develop respiratory depression because of severe hypophosphatemia. We actually had a patient several years ago that was one of our PN patients, home PN patients, who came in with an AKI, and so actually his phosphorus was pretty high. So we reinitiated his PN and left the phosphorus or phosphate out because he was hyperphosphatemic and remained hyperphosphatemic throughout his stay here at the hospital, which was about 5 or 6 days. Was going to be discharged back on his home PN. So I reached out to the home PN company and said, there's no phosphate in his PN because he's still hyperphosphatemic, but do know that he is probably going to need some, I would say probably in a week or maybe less. So I would appreciate if you guys would follow up with that and, be sure that we're looking at his phosphorus. And so the pharmacist kind of blew me off. Yeah, I know that, whatever. So they sent the patient home, and again, there was no phosphate initially. So they let the patient go almost 2 weeks without any. The nurse came out to see the patient. He was having difficulty breathing. Sent him to a smaller hospital, did a chest x-ray. They were thinking pneumonia. Chest x-ray was clear, so they sent him back home. Nurse came back out a couple of days later. His O2 sat was in the 80s. Was having really difficulty breathing, so went back to the hospital. They did get electrolytes and found his phosphorus to be less than 1. And so really saw almost a paralysis of the diaphragm in this particular patient. So it came back to us, and it took us really a week to correct his phosphorus. So that really a lesson there. That's something you want to watch for. Anytime you see a PN without any phosphorus or phosphate, be watching that. So that was really a case that turned out okay, but could have been certainly detrimental, if you will, if it had not checked those labs. Think about hypokalemia, hypomagnesemia. Again, I'm thinking about cardiac issues here, muscle twitching, even can lead to things like convulsions and seizures if these are severely depleted. Thiamine deficiency, we think about the patients being encephalopathic. You can see things like Wernicke's. There's wet versus dry very in the literature as well. The sodium retention, like I said, this is a little bit older table that was taken out of a 2005 publication. Sodium or fluid retention is not a big problem as we thought at one time. So we primarily focus now on phosphorus, potassium, and magnesium and thiamine in these patients. But again, a very nice table that kind of outlines some of the signs and symptoms. So we also looked at some published recommendations regarding refeeding syndrome. And so this is a table, again, taken from the paper. And so we looked at NICE, which is the National Institute for Health and Care Excellence. We looked at the Irish Society, and we also looked at Clinical Nutrition Steering Group here. And you can see that they all have some recommendations in terms of initial calories, how to advance, and some other recommendations listed there as well. As you note here, we're looking at pretty low amounts of kcals initially, in general about 10 to 15 kcals per kilogram with those recommendations. Also looked at a couple of trials too that looked at lower amounts of kcals in terms of introducing into those patients that are at risk, and honestly not advancing these until the electrolytes are normalized and the patient is stable. I think that's the key. And sometimes that can take, quite a period of time. I've sometimes had physicians say, why are they only at a small amount? the rate's really low. I said, well, they're still refeeding. We're still trying to correct some of these electrolytes. We can't, advance their PN or their enteral nutrition until we correct some of these abnormalities. So again, really sometimes a lack of understanding that we see in practice. The paper also really introduces, if you will, some consensus criteria for identifying adult patients. There's also a table that looks at pediatric patients as well. But I just thought I'd just show the adult patients at risk. So this is looking at moderate risk, 2 risk criteria needed versus significant risk with 1 risk criteria. So here you're looking at a BMI from moderate risk of 16 to 18.5. And a patient with significant risk less than 16. Weight loss noted here from moderate and significant. Things like caloric intake, abnormal pre-feeding electrolyte concentrations, broken down to moderate and significant as well. Patients who have lost subcu fat or muscle mass, and any comorbidities also can certainly be involved in identifying these patients, whether they're moderate risk or significant risk. I think this is very helpful, something we also use in our practice here when we're trying to identify those adult patients. And again, like I said earlier, there's also a pediatric table. So if you do any peds, you might find this helpful too. This paper is actually available on the Aspen website. If you're not a member of Aspen, you can still access this through nutritioncare.org. And I believe this paper is under the guideline section, which is broken down into parental nutrition. And this paper is actually in the parental nutrition section. But if you don't have this paper, I would encourage you to get this, especially if you have students or residents. I think it's a very helpful paper to introduce them to the concept and to understanding what we do here. The other portion of this paper, this is table 6 that's in the paper of the consensus recommendation paper, talks about how to initiate, again, with a lower amount of dextrose, somewhere between 10 and 20 kcals per kilogram. I would say here in our practice, we're more like 10 to 15 in that first 24 hours. And then we advance, this is advanced by 33%. We advance probably a little bit slower than that in our practice. Again, depends upon, if they're moderate or severe risk as well. The other thing that I would also think about, if you're in the acute care facility or practice, look at other calories from IV dextrose, whether that's IV dextrose fluids or even piggybacks with antibiotics. You need to take those into consideration again, because that's an additional carbohydrate load. So be sure you're looking at that and taking that into consideration when you're looking at your total kcals per kilogram. Now, in our paper, there was really no fluid or sodium restriction recommendation, again, because newer literature would indicate that's not necessary, nor protein restriction. One thing we do sometimes do is, because of the stability of the parental nutrition, we may not start at goal protein. So that's something to think about as well, especially if you're doing 3-in-1s with amino acids, dextrose, and lipids. If you give too much protein initially, that may affect your overall stability of your 3-in-1 or your TNA. So take that into consideration as well. So we oftentimes don't start at goal protein, but we don't necessarily restrict it either. In terms of electrolytes, be sure you're checking those before you initiate, like I said earlier, and then even monitoring every 12 hours with a patient at severe risk. You want to be sure that you're replacing those. Some people have a protocol in place. We do have an electrolyte replacement protocol in our facility. Is not necessarily deemed a refeeding, but we oftentimes will use that, at least in our place, in our shop, to help with this. And again, repleting those is really important to do that. So you want to advance very slowly in these patients. Thiamine, multivitamins, we know we probably need to supplement thiamine in these patients, and find some of the literature that would indicate maybe higher amounts. For most patients, I would say probably 100 milligrams for 5 to 7 days is a sufficient amount. One thing that's been a challenge for us, and maybe even in your practice, if you're in the hospital or acute setting, is MVI, multivitamins for injection. There's still a major shortage here. So we're down to doing it 3 times a week in our institution. So in this patient, then, you may not be able to do it on a daily basis, but if you can, that's preferred. If not, we may, on those alternate days, have to give maybe oral or enteral multivitamin to meet their needs, and hopefully they can absorb that. Some of them can, some of them cannot. But MVI is really a challenge right now, and I'm hoping maybe in the next couple of months that we'll be through that. But again, it tends to rear its ugly head every few years, so we are always constantly dealing with some shortage. Also recommends vital signs every 4 hours for the first 24 until the patient's stable. Thinking about cardiorespiratory monitoring, very important here as well, because there's certainly a risk of cardiac arrhythmias or even respiratory depression. So again, you want to be sure that you start slow and you really work your way up very slowly as well in these patients. This is a really interesting journal article that I found a few years ago. It was a 2019 publication. And it was entitled "The Refeeding Syndrome Revisited. You Can Only Diagnose What You Know." And it was a German article looking at the awareness of refeeding syndrome. It was published in the European Journal of Clinical Medicine, 2019. So what they did, they had this questionnaire. They had a case vignette that involved an older person who had a significant weight loss and was at risk for potentially developing refeeding syndrome after one would initiate nutrition therapy. And so these were primarily German physicians and fifth-year medical students in Germany, and in 7 centers in Germany is where they did this study. And so when you look at the data here, I've outlined, highlighted some of the things I wanted to point out. So if you look at the gender here, 59% of these providers were female, and they were all from the 16 federal states of Germany. So all those federal states were represented. When you look at the participants, majority within that age of 21 to 40, and about 55% had less than 5 years experience. Most of the responders were either internal med or geriatrics. And interesting enough, they had about 4% of those that were in that answered the survey were actually had completed a certified postgraduate course in nutrition medicine in Germany. And this again just outlines that primarily geriatrics, internal medicine were the majority of people who responded to the questionnaire and to the case vignette. And so there was a total of 281 participants that completed the questionnaire, and only 14% correctly diagnosed refeed syndrome in the case that they were given. About 8% gave a nearly correct answer. So in other words, they described some type of electrolyte or metabolic disturbance here, and derangement or derailment here. So when you look at this, think about this, about 78% of those participants weren't able or didn't diagnose refeeding syndrome. So I thought this was really interesting. And honestly, I would kind of like to do this in my own facility just to kind of see. I don't know if I could get away with it or not, but I would suspect that we would probably have a pretty high percent of folks that would miss this if this were given to our providers here in our facility. When you look at the highest rate of diagnosis, 36% of those that diagnosed it right were internists, 45% were geriatric medicine folks, and those that were certified in nutrition medicine, 56% of those diagnosed that the patient had refeeding syndrome. And as I mentioned earlier, you walk through looking at refeeding syndrome. Primarily, you're going to look at case reports, and this is one I found in the Asian Pacific Journal of Clinical Nutrition. As an 87-year-old female that's Alzheimer's, admitted to a hospital with poor general condition. You can see what her weight is, and her BMI is 16. So when she presented into their emergency department, she was hypernatremic. So thinking probably more of a free water deficit. So they actually initiated D5W in this patient who was 87 years old. So you think about that, that's a carbohydrate load they initiated. So the patient might be at risk for refeeding. Because that she had dysphagia and they could not place a feeding tube, had difficulty getting one down, they decided on day 2 of admission to start PN. And they started the patient at 30 kcal per kilogram per day. So pretty much a little higher than the goal rate, honestly, especially in someone this age. On day 4, they actually consulted a physician and a team that had a nice background in nutrition. And they noted that the patient had deteriorated. They had severe electrolyte imbalances, primarily hypokalemia. So at that point, they actually discontinued the PN, and they were able to get a feeding tube, and they initiated EN at a very low rate of 10 kcal per kilogram per day. Again, this just kind of outlines some of the labs here for you. Now, some of their normal ranges are different than what we would see in the US, but primarily, if you look around day 2 and day 5, you can see the patient has pretty severe hypokalemia. Their phosphate level was just slightly low. Surprisingly, I would have thought it'd been lower than that. But when you look at their normal range, it was at 0.8. Their range was 0.9 to 1.3. Magnesium was slightly low too. So this patient actually was at a major risk, and starting a D5W in the ED and not getting baseline labs probably was a major error, a major mistake, and it's noted within this paper or this case report as well. Some of the things that they missed, in this facility. So again, a lot of case reports out there more than anything else. I wanted to share with you one of the patients we recently had here. So this was we still have a nutrition support team. So we have a myself, pharmacist, we have pharmacy students, pharmacy residents, dietitian, and a medical director. We no longer have a nurse, unfortunately, but we do still have our team in place. We were consulted to initiate PN in a 72-year-old male that had a total colectomy, ileostomy, still had NG tube suction, just hadn't opened up, and was at that point kind of out to about more likely around 5 to 7 days. And so they had already placed a pick when we were consulted. Past medical history, past surgical history, the patient had colon cancer, hypertension, diabetes. Again, if you live in Mississippi, pretty prevalent. I think we're #1 in diabetes. We Louisiana and Mississippi, we fight back and forth to see who's #1. I think we're back at #1. So not a good thing to brag about for sure. Patient had several small bowel resections, as noted here. And you can see that they're 70 inches and they weigh 50 kilograms. And so baseline labs here, you can see their potassium at 3.2. So they're hypokalemic. Their phosphorus is at 2, their mags at 1.5. Again, because they do have a history of diabetes, their glucose was elevated as well. So some of the concerns we had as a team is their BMI was 16.5. All their electrolytes baseline are low. Glucose is greater than 200. Patients had a recent weight loss as well. And they were actually receiving some dextrose containing fluids post-op. So that was noted as well. So that's something that we had to deal with. So this is a case where we're, again, not going to start PN in this patient until we correct all the electrolytes and we get glycemic control. And then we're going to initiate probably here about 10 or 15 kcals per kilogram before we would not advance until everything glycemic control was in place and electrolytes are normalized as well. So this is one of the challenges we see here. So I turned this just a little bit because Stephanie asked me maybe to think about this more from an outpatient standpoint and how you would deal with this. So we got the same patient here, right? But they want to place a G tube in interventional radiology. And so you're thinking about this, you get consulted, and would you be comfortable starting enteral feeds in this patient as outpatient, right? And so I think about it from my perspective. A lot of times this comes up with parenteral nutrition. They'll call me and say, hey, we have a patient who is a candidate for home PN. We'd like to start this at home. And honestly, I try not to. And most of the time I can talk them into maybe admitting the patient because I explained they're going to be some abnormalities that occur more than likely, especially if they have the cachexia, they've had a lot of weight loss. We're going to need to deal with that. And, doing that on an outpatient basis is very difficult. It's hard to get those boluses out there or even maybe some volume that you need to give the patient. From an outpatient perspective, that's very difficult. So think about your own practice and, would you be comfortable starting this patient on enteral feeds outpatient? Knowing what you saw, right? So in my opinion, I'd love to hear what others have to think. I would want to get, honestly, I probably would want them admitted. I definitely would get baseline labs. And I would think about it, if I have all these abnormalities, can I really address these in the home environment? Because in general, we're going to have to do this intravenously, right? Because if they're severely depleted, we're not going to be able to correct those via the oral route, and especially with magnesium, right? It's poorly absorbed. We try to give higher doses of magnesium that typically will cause diarrhea in these patients. So that would be my concern, but I'd kind of like to turn it back to you as clinicians and see what your thoughts are. How would you address this? Would you ask they be admitted, or how would you tackle this?
How do you want us to respond? Like in the chat?
Yeah, that's why you could just, or so you could just open it up for if you want to come off your mute and talk about it, that's fine. Looks like there's something in the chat here. Let's see.
So Andrea said she'd be wanted to be admitted.
Yeah, I would agree. I would definitely try to admit this patient. I have dealt with some of this on an outpatient basis, especially with parenteral nutrition, and it is very difficult to correct. I would definitely recommend admitting them. Good. I mean, I think so too. Now, and I think that you have to maybe explain to the provider the challenges in trying to correct some of these abnormalities outpatient. And, it's not that they can, sometimes a nurse only comes out once a week to give this. And so trying to get these boluses out there uh, to these patients, do they have access? And oftentimes that may just be peripheral access. So how much can you actually give in terms of boluses peripherally is also a challenge. So I definitely would agree that I would do my best to have this patient admitted. So I want to just see what questions you have. I kind of walked through some of the things that we deal with in our facility, and I wanted to ask, are you familiar with the paper? Is the group familiar with the paper? Have you seen it before? Right.